So, good evening, everyone. I would like to welcome everyone for the Journal Club. And I would like to welcome our first expert, Dr. Manjusha ma'am. She's a senior consultant obstetrics and gynecology, Max Healthcare Lucknow. Ma'am is a UP chapter secretary IFS 2020 to 2024. She's executive member of the LOGS, APGL, and AGOI. She's organizing committee member. She had been organizing committee member of AGOICON 2022, AICOG 2020, AICC RCOG 2018, and Fertivision 2016. Ma'am is teaching faculty of MRCOG courses of RCOG, and she has numerous publications and review of 400 maternal deaths at a government facility, Delhi, and cesarean audit at a major corporate hospital. I welcome you, ma'am, for the as an expert. Thank you so much for coming. And Rudri, the next slide. So the second expert is Dr. Hitendra Sumani, sir. I welcome you, sir. Sir is Secretary of IFS Gujarat Chapter 2024-26. Sir has been past Joint Secretary IFS Gujarat Chapter and past President of Bhavnagar Obstetrics Gynecology Society. And sir is director at Nirmal IVF Test Tube Baby and Advanced Laparoscopy Center, Bhavnagar. Sir has been awarded the Atmanirbhar Award at Gandhinagar 2021 at the hands of Chief Minister of Gujarat. Sir has numerous publications and presented papers in many national and state level conferences and attended many national and state level conferences as faculty, speaker, and panelist. I welcome you, sir.
Thank you. Thank you.
Rudri, the next slide.
Yes.
So today, Dr. Rudri Agarwal will be presenting the Journal Club, and she's consultant at Nova IVF Center, Ujjain, and she's received a lot of awards, a lot of academic awards, and she has special interest in reproductive medicine and infertility, reproductive genetics, and immunology. So, Dr. Rudri, please, you can present your Journal Club now.
Yes, ma'am. Okay, so thank you so much, Ankita ma'am, for the kind introduction. At the outset, I would like to thank Indian Fertility Society and President Dr. Pankaj Talwasar, Secretary Dr. Shweta Mittal ma'am, our experts Dr. Manjusha, Dr. Hitendra Somani sir, and of course Dr. Ankita ma'am, and for giving me the opportunity to talk over the subject. And I'm Dr. Rudri Agrawal, going to present a review of the article titled as Bariatric Surgery for Spontaneous Ovulation in Women Living with PCO. So it is known as Bambini trial, which is a multicentric open label randomized control trial, which was published in year 2020-24. So as we all know that polycystic ovarian syndrome is the most common endocrinopathy in the women of reproductive age with a prevalence of nearly 18%. Also, it carries 15 times higher risk of anovulatory infertility, along with 2 to 3 times higher risk for the adverse pregnancy outcome as compared to their counterparts without PCOS. Further, when PCOS is superimposed with the obesity, it poses a great challenge for the
Excuse me, ma'am.
clinician
Sorry.
as well as for the patients.
Excuse me, ma'am. Ma'am,
Yes.
slides are not changing. Sorry for the interruption.
Okay. I apologize. Yeah.
Thank you.
So, yeah. So, the Bambini trial is one of the first of its kind, and it is one of the first randomized trial comparing the effects of bariatric surgery with the medical care by the biochemically confirmed ovulatory rates in the women with PCOS and obesity. So this is the material and methods, where this is an open labeled RCT and it was conducted in 2 academic clinical centers in United Kingdom, and the consort guidelines were followed to report the study. So the consort guidelines are some of the consolidated standard for reporting the randomized control trial, which are primarily intended to report the parallel groups. That is what has been done in the Bambini trial also. So there were 80 participants and 40 in each. All were of age more than 18 years and with a diagnosis of PCOS confirmed by 2018 guidelines. So when this trial was initiated, there was the guideline available, which was of 2018. Currently, we are talking in 2025. Now we have the updated guideline of PCOS, which was released in 2023. Again, the participants has the BMI of more than 35 kg per meter square. The key exclusion criteria for this trial were diabetes, and the patients who were being unable to maintain the non-hormonal contraceptions, who were having pregnancy or who were breastfeeding their neonates, or with the GERD. So this was the consort guideline in which they selected some 100 patients, 20 were excluded because they probably did not meet the exclusion criteria or probably they have declined to participate. Then 80 patients were randomly assigned and they were assigned each into two groups. The 40 group of one patient which were given the pharmacotherapy to reduce the weight loss, and again the another 40 patients who were given the surgical interventions. So the participants were offered pharmacotherapy in the form of metformin with the maximum dose of 1 gram twice daily, and orlistat, which is a GLP-1 agonist, and the maximum dose was 120 mg thrice a day or a combination of two. The another group in which surgical intervention was done, there was a laparoscopic sleeve gastrectomy was performed. And as we know, there is a surgery in which this is a surgery in which we reduce the size of the stomach. Thereby, it helps to feel the satiety earlier and reduces the hunger of the patient. Along with it, reduces the ghrelin hormone secretion, which again further reduces the appetite of the patient, and thereby it helps in the weight loss. Postoperatively, the individuals were assessed at the interval of 10 days, 6 months, 12 months, and by a dietitian at the 3 months interval. Then the follow-up duration was of 52 weeks, and all the patient underwent venesection for the measurement of serum progesterone at the weekly basis. Participants were also assessed once every 4 weeks at the Clinical Research Institute for the measurement of their anthropometric, cardiometabolic, reproductive, and safety endpoints, which are discussed in the subsequent slides. Every 26 weeks, the participant also underwent a standard 75 OGTT test, the measurement of glycosylated hemoglobin, and the evaluation of clinical hyperandrogenism, along with quality of assessment. And all these tests were done based on the blood values and some sort of pre-formulated questionnaires. And the primary outcome was the trial was number of biochemically confirmed spontaneous ovulatory event, which is again one of the strength of this trial, because in this trial, the ovulation was confirmed by the progesterone value rather than ultrasound done by a sonologist or a gynecologist, which may be again a source of error due to the subjective differences. And the ovulation was defined in this trial as a rise in the serum progesterone 16 mol per liter on more or two or more occasions. And the endpoint is considered as the best predictor of pregnancy in the women with PCOS and obesity. Now, if we look at the observation of the study, then they have observed that there is a significant difference between the incident rate of the ovulatory event in the medical group. The incident rate, the mean incident rate was 1.9 as compared to the surgical group, which in which it was 4.1%. So there is again a very statistical significant difference between the two groups in terms of ovulatory events. Further, the median number of ovulatory events was also higher in the surgical group who underwent the bariatric surgery. Also, there was a significant change in the body weight observed in the surgical group as compared to the group in which the pharmacotherapy was given. There was also a significant difference in the incident rate ratio of reported menstruation during the 52-week follow-up between the surgical and medical group. So this is the detailed analysis of the study in which primary outcome and the secondary outcome was compared on multiple points. Now, as you can see, the p-values marked by the blue asterisk. So the primary endpoints when we compare it, so it was a significant difference in terms of incident rate of oocyte ovulatory events and the median ovulatory events. In the secondary endpoints, if we compare, then again there was a significant difference between the weight loss, between the fat loss percentage, the waist circumference difference, the systolic blood pressure difference, the diastolic blood pressure difference, and the fasting glucose. So in all these points, in all these outcomes, there was a significant difference observed by this trial between the two groups. Then these are the metabolic endpoints in which again they have observed a significant difference between the waist circumference, the again the blood pressures, and the HOMA IR also is a very important thing, which
Dr.
is
Gupti, we
a
cannot see that slide. I think
sorry.
we
Yeah,
cannot see
okay,
the
okay.
slide for the
Yeah.
biochemical one.
Yeah. Okay. So they have observed a very statistical significant difference between the HOMA IR scale, which is a scale which shows that how resistant is your body towards the insulin. So again, they have observed a very good significant difference and the decreased insulin resistance in the surgical group. Then this is one of the again the some secondary endpoints in which there was a drastic improvement seen in the groups in which the surgical interventions was done. And in the reproductive endpoints, the Bambini trial has observed a significant difference in terms of only sex hormone binding globulin. Rest all other hormones, they have not observed any significant clinical difference. Then again, they have observed a significant difference in the levels of anti-Mullerian hormone or the cycles, the self-reported menstrual cycles, and the testosterone levels also. Then, in the androgenic endpoints, there was no significant difference between the Ferryman-Galway hirsutism score or the Ludwig visual score for the androgenic alopecia or the Cardiff acne or the Savine alopecia score. But they have observed a significant clinical difference in the PCOSQ score, which is a quality assessment in the PCOS patient, stands for the polycystic ovarian polycystic ovarian score for the quality of life in the PCO patient with the obesity. So they have observed a significant difference at the end of 26 weeks and at the end of 52 weeks also. So this is again some of the routine life questions which they have asked to the participants, and they have observed the significant difference between their energy fatigue level, their emotional well-being, their social functioning, and overall improvement in the general health in the surgical group. So to discuss and to compare the Bambini trial with the other studies, we have observed that again it is one of the first randomized trial, and this trial provides an evidence for the additional option for the women with PCOS who do not respond to the pharmacotherapy or do not tolerate the behavior or the pharmacological treatments. The trial showed that after the vertical sleeve gastrectomy, the women had a significant higher rate of spontaneous ovulatory events, approximately 2.5 times higher as compared to their counterparts in the medical group over a period of 52 weeks. Then again, if we talk about the ESHRE and ASRM consensus 2023 for the evidence-based guideline of PCO, they said that there is the consensus recommendation regarding the bariatric surgery. It is not an evidence-based recommendation, but a consensus recommendation regarding the bariatric surgery. So they say that bariatric surgery could be considered to improve the weight loss, hypertension, diabetes, irregular menstrual cycle, ovulation, and pregnancy rate in the women with PCOS. Again, if we talk about the same guideline in terms of metformin, then there is an evidence-based recommendation that metformin alone should be considered in the adults with PCOS and a BMI of more than or equal to 25 kg per meter square for the anthropometric and metabolic endpoints, which the Bambini trial has shown the same result. Then this is something related to the Orlistat. So there is again the consensus recommendation, not the evidence-based recommendation in terms of use of anti-obesity pharmacological agents. So if we compare this Bambini trial with the study done by Dr. Mohit Bhandari et al., so the findings were in strong agreement with the study, and they have observed that the 1013 patient with the PCOS who underwent bariatric surgery, and then they have reported that 93% of the women had complete resolution of the menstrual dysfunction post-operatively, and the remaining 7% of the patient reported regular menses at the end of 2 years post-bariatric surgery. Again, this is the same study. And with which the Bambini trial is in strong concordance, which suggests that there is a complete remission of PCOS. And in the patients with obesity, depends on the final BMI after weight loss. Thus, bariatric surgery should be prioritized for these patients. So this is one more study which says that weight reduction after bariatric surgery improved the menstrual irregularity as measured by the duration of intermenstrual interval. Then this is a study which contradicts the Bambini trial, because in Bambini trial, despite reductions in the biochemical hyperandrogenism, surgery did not consistently improve hirsutism, acne, and androgenic alopecia. And they have given the explanation for this, that this clinical hyperandrogenism could be a very resistant complication of PCOS which do not respond to the weight loss. So again, these are various studies which shows their results on the forest plots, and they have compared the groups in the pre-bariatric surgery and the post-bariatric state. So they have observed the significant difference in the pattern of menstruation, in the terms of hirsutism, in levels of total testosterone, and in terms of free testosterone. They have observed the clinical significance in the patients who have underwent the bariatric surgery and a significant improvement in this group of patients. So the strength of this trial was that it was a randomized trial. The follow-up period was of 52 weeks, which is a significant period, and the objective measurement of ovulation rate was done using serum progesterone, thereby eliminating the subjective bias. Also, extensive cardiometabolic and psychological phenotyping of the participants were done. Standardization of phase of menstrual cycle again done, depending by giving the medroxyprogesterone acetate to all the patients, and all interventions were done once they have their menses. Then standardized reporting of the endpoints using core outcome set for harmonizing PCOS research. Then some of the limitations of this trial were that it was an open label design. That means the participants and the researchers both were aware about the interventions being done in both the groups. So again, it may create a sort of bias, which is one of the limitation of the study. And then for the diagnosis of PCOS, the guidelines of 2018 were considered, but the explanation for this could be that when this trial was initiated, there was only this guideline which was available. And now we are in 2025, we had the 2023 guideline available with us. And the trial endpoints did not include the pregnancy or live birth, as this would have required a much longer duration to follow. So in the end, I would conclude that the bariatric surgery require further more clinical trials to prove its efficacy, and bariatric surgery could enhance the prospects of the spontaneous fertility in the women with PCOS and obesity. Also, by reducing the cardiovascular and metabolic risk in the women with PCOS and obesity, it could improve in the clinical pregnancy rate, simultaneously reducing the risk of obstetrical complication and NICU admission in the neonates. Thank you so much.
Thank you, Dr. Rudri. Dr. Manjusha, Dr. Tenda, if you want to ask any questions to Rudri, or should we discuss any points?
Yes. Um, Dr. Rodri, this study has brought out the salient feature, and also you have shown a comparison with so many other studies which have been done on similar subjects. One question I would like you to clarify that in the control group, that is a surgical group, we had 30 women, and in the medical group, we had
Ma'am, voice
30.
break is there.
Are you able to hear me now? Am I more audible now?
Ma'am, you're audible, but there's a slight voice break.
Okay.
Yeah, it is much better now.
Yeah. Okay. So what I'm asking is that
Hmm.
do you think that a study with a test volume sample size of 30 and a control of 33 adequately
Mhm.
powered to make a conclusion like this?
No, definitely not, ma'am, because the trial itself has said that they need at least 35 patients in each group to have a confidence interval of 95%. So definitely this is one of the major limitation of this trial.
Yeah. And
Yeah.
one or two more limitations you have already said that one, it is a open label because obviously a double blinded is not feasible. And
Yes, ma'am,
then
because the patient had undergone the surgical
yeah, of
intervention, so
course. So it
double
is not
blindness was
possible.
not possible.
And
Correct.
second thing, you have also mentioned that pregnancies and childbirth would have taken much longer. One more question
Definitely.
I would like to ask you. You have already compared it with the Indian trial by Bhandari et al. So, what do you
Yes.
think is the importance of measuring progestins vis-a-vis the intermenstrual duration which Dr. Bhandari et al. Have showed?
So, ma'am, it again depends on the researcher's preference. So, it depends then, what parameters do have, what parameters all those researchers have taken into account. So, if we do not do this in this way, then also it is, it can be done if we measure the ovulation by the sonography, but then it may be a source of subjective error. So, it was better documented as biochemically proved ovulations.
Yeah, that's a very valid explanation. But
Yes,
I think that this way of measuring progesterones, besides making it more objective, would also correlate more with the ovulation happening. Because, even sometimes we can have non-ovulatory menstrual cycles as well. So measuring
exactly.
just the intermenstrual duration would not show us that the ovulation has returned. Uh,
Yes, yes,
yeah,
absolutely. You are
yeah.
definitely right.
And one thing more, like this study happened before the semaglutide thing was available in the UK market. So now that semaglutide is available and is FDA approved,
Hmm.
we might be needing more studies on this subject because it has
Yes,
really come up in a
definitely.
big way.
Yes, yes. And one
Uh,
of the major concern regarding using that semaglutide is that we have to advise a very stringent contraception to the patient because the safety data over the use of these drugs are very less as of now. Yeah.
yeah, very true.
Excellent.
Um,
Yes.
Dr. Hitendra, please.
Yes. Excellent presentation, Dr. Rodri. See, I want to ask you, did you notice any changes in medical treatment group because they received metformin? Was there any ovulation, spontaneous
Yes.
ovulation?
Yes, sir. Yes, sir. There were incidences of spontaneous ovulation, and one or two patient, got pregnancy due to that spontaneous ovulation also in the medical group.
Okay. And
Yes.
one more thing, this doing a obesity surgery, does
Hmm.
it cure? See, if all the parameters, 80% of the parameters changed, but does it
Yes.
cure PCOS?
So I don't think so because, sir, this is one of the thing which we are doing in hope for the weight loss, and then due to the
Yes.
vicious interplay of the hormone, it gets corrected and the patient gets pregnancy. But definitely, it will not resolve PCOS in the long run, and it may again trouble the patient. Yes.
Because that pathophysiology is going to remain. And
Yes, definitely,
when
sir.
they come back
Definitely.
to us for IVF, see, we have on many occasions we have done IVF for such patients.
Hmm.
Like we advise them bariatric surgery, and after getting done bariatric surgery, they come back to us. The weight is reduced, their parameters are reduced, but their PCOS morphology is not changed. It remains more or less the same. But their tolerance to IVF, the outcome of IVF,
Improves.
drugs required, everything improves. And most important factor is that obstetric outcome tremendously improves after bariatric surgery.
Definitely, sir, because the obesity itself carries a high risk for the pregnancy, adverse pregnancy outcomes. Yes.
And the results of weight loss following bariatrics, we at least expect them to be long lasting as compared to what we achieve with lifestyle and the medical management.
Yes, ma'am, because again, ASHRAE 2023 suggests the lifestyle modification as the first line of treatment in the patients of PCOS with obesity. So definitely there are some things which need to be followed by the patients after undergoing the bariatric surgery. Otherwise, they may put weight very quickly. Yes.
But basically, this is only for those patients who are morbidly obese. They're having more than 40 BMI, or they are having more than 35 BMI with some kind of risk factors.
Correct, sir.
But obesity is becoming a lifestyle disease now. The
Yes, sir.
incidence is so
Obesity as
high.
well as PCO has become a pandemic sort of
Yes.
thing.
See,
Yes, sir.
previously we used to see for cesarean, almost patients were average 80 to 90 kgs. Nowadays, all CS patients are mostly 120 kg, 125 kg. So it's very,
Yes, sir. Every now and then we see the patients in our OPD as having severe PCOS with obesity. That is a very common thing nowadays.
and second thing I've seen, some patients, they conceive one pregnancy spontaneously, but after that they start gaining so much of weight and there is so much of PCOS increase that they find a lot of difficulty in becoming pregnant for the second pregnancy.
Yes, sir. Absolutely, sir.
Is Dr. Jayesh there? Any input?
Yes, Dr. Somani, I'm just hearing the everything
Yes.
which
We're
was
waiting for your input,
good
sir.
going on. Only the highlighted point is already that most important part is confidence interval. So the number of the patient, which was the actual number of the patients, which might be already told by the everybody that it is lesser than what we required. That is one thing, because if we see the confidence interval and number of the patient which is required to prove that. Second thing is right that up to 33 BMI, still we are freeze all, and we can have a something crash weight reductions, right? But whenever there is more than 35, or maybe this is about the very morbid obesity, it's a big problem. And I think so still there are more studies required to say something about the weight reductions by the some other molecule which will reduce the weight within that 3 or 4 months, and we can transfer the embryo. I think so there are big freeze, another freeze data which was available, that there is no effect on the oocyte uh, and embryo conversion rate, but there is a big effect on the ongoing pregnancy rate and the delivery rate when there are obesity is crossing. Morbid obesity will be there. So we have a certain experience, but I think so obesity and PCOS both are a different conditions. Individual 90% of the PCOs are always having a different abnormal LH peak, LH surge will be there, means LH quantity will be there, and obesity is one of the part of that abnormal LH secretions from the central nervous system will be there. So it's very difficult to manage the both together, and it's a very difficult conditions to for the ongoing pregnancy and everything. So it's a, I think so for the future more studies required, that and I'm much more in looking forward for the more of the medical management rather than surgical management, because we need to explain the surgical management do have a certain problem like IUGR and preterm delivery. Everything is associated with the post surgery obesity, bariatric surgery that we observed. So proper counseling is also required, that it's not like that you will go for the bariatric surgery and the it's a very red carpet for ongoing pregnancy rates.
Thank you, sir. Thank you for the comments. Actually, we have two questions in the chat box. Actually, one is just an opinion, not a question, actually, that now there is a gastric balloon available which can be put inside by endoscopy. So that's a non-invasive way sort of thing for weight reduction. So, Dr. Rudri, do you have any comments on that in terms of this saying ki gastric sleeve surgery is not required? Other endoscopic way of gastric balloon is available. So that's less invasive, but I think that does a similar action.
Yes, ma'am. The mechanism of action is again same by reducing the appetite and reducing the level of ghrelin hormone, which again will reduce the appetite. So there is not much difference. Again, we need to take a expert opinion regarding comparing the two surgeries. Right.
I had one patient who went to Dr. Mohit for balloon, and she lost 12 kg weight in 3 months. But then she did not become pregnant, and within 9 months, her weight was same back where it was.
Oh, okay. Okay, sir.
So the
So,
effect is all temporary.
I
right.
want to ask if anybody knowing, because I don't have a much more experience on the 35 BMI and much more patient treated. I want to ask something, that are you having some number of patient experience where you are giving some interval balloon therapy, or interval some new molecules are available, or which is which is more preferable? Is there any answer from the other people, those who are having some experience, then they can share their experience? That are you freeze and then suppose interval 3 4 months, if you go for balloon or if you go for any medical management and reducing the weight around 10 to 15 kg, and then immediately we can transfer the embryo? Is it how it will be miss how you people are having any experience for that?
Jay, so this is Ankita. I'm using the standard protocol only in the sense lifestyle modification and metformin and mannitol
Yes.
combination. I've not tried this experimental way. The second thing is pediatric surgery. I would like to ask you because I acceptability. I have counseled patients for pediatric surgery with BMI of 40 or more than 35 with comorbidities, but the acceptability is less. I have patients who say just do my embryo transfer, we'll see what happens. They
Yes, yes. So,
some
mm,
even say, "Ki don't I we cannot lose weight. Let's just attempt the embryo transfer." Recently, I had a patient. So I told her it's very less likely that you'll become pregnant, but she doesn't want to lose weight. She doesn't want pediatric surgery. She doesn't even want to give it a try. So,
Hmm.
uh, I don't know. I think other seniors can answer better than if they have experience with this.
Anybody those who can advise something crash weight reductions, means there are a lot of things now for diet, and there are a lot of people are claiming that we can reduce the weight by 10 to 15 or 20 kg by 3 months, and then you can transfer the embryo. I think so. I started to explain like that, but I don't have a very vast experience to say something, because I'd seen something in the prison scenario. There are a lot of patients are reducing weight with 110 kg to 90 kg. I'd seen people to reduce, and I think so that 20 kg reductions might sometimes enough to transfer the embryo, because ultimately whatever the patient, those who are having a BMI more than 35, yeah, they are always having a weight which is more than 100 kg. And I found that whatever the BMI configurations, and what are the weight extremities, whenever you are having a weight which is less than 90, the ongoing pregnancy rate is at that BMI will be pretty fine, pretty good, if patient is maintaining their hygiene and antenatal visits. What is what is the other people's suggestions?
Fine. Yes.
I think so that that is what we can do something more about the high BMI. So thank you for my from my side. Anybody can ask the question.
Actually, bariatric surgery remains a very tough.
Manjusha ma'am, you're not audible.
Can you hear me now?
Slightly better.
Okay. I'm saying bariatric surgery.
No, not audible, ma'am, not audible.
Okay.
There's another question in the chat box. When can the patient be taken for IVF ET after pediatric surgery?
Yes. Ma'am, this question particularly, I've seen one patient who underwent IVFET immediately after 6 months after bariatric surgery. But those patients who go for early IVFET, they have lot of hyperemesis. They have lot of first trimester symptoms that they are most of the time on vitamins, multivitamins, and they require parental IV fluid support. So let them reduce the weight, let their weight get settled, and preferably go for IVFET.
I
Because
think so.
there
There
is
is a
always
guideline
a
which is saying post bariatric. I think so. You need to start IVF. Exactly, I can't remember, but it's 1 year to reduce the chance of IUGR and the preterm delivery.
Yes,
I
yes,
think so.
so
There is
it's
a guideline.
12 months, like 1 year, 12 months.
1 year.
Because
Yes, there is a guideline. You can't start IVF before 1 year.
plus because they have the micronutrient deficiency that is there post
Exactly.
pediatric
And the
surgery. So
reason for this
at
is
least 1 year is there.
the malabsorption syndrome, which is seen after the bariatric surgery. The incidence is very high for the malabsorption syndrome.
So the
So
answer, yeah, 1 year, at least minimum
one
one
year.
year gap should.
1 year. Yes, yes, yes.
I had one question, seniors and Rudri and JS, sir, if you could answer. I have just seen a couple of cases, not much, a post-pediatric surgery. One or two patients I had seen which actually turned from PCOS to sort of a POR. It's very, I don't know, just one or two patients. So I just wanted to ask your opinion. When I was in AIMS, one sister who was 120 kg got a pediatric surgery done, and she was a hard, like severe PCOS, but when in terms of IVF we had to do it, she genuinely had a very reduced antral follicle count.
So
Any
we
experience
don't have
with
any
that?
experience.
So
No,
means just like it, maybe it could be just an incidental finding in her case.
maybe,
But the only
maybe.
explanation which I thought was micronutrient deficiency that could have taken place post pediatric surgery. That's the only logic I understood. And I had discussed with couple of people and they also said the same thing.
Hmm. Actually, we should think about it at which symptoms and at which level of the BMI, and at least we don't know the threshold at which level of the BMI and the weight that we should advise the patient for always bariatric surgery. Still, it is a question mark, and I still believe that days will still experience will tell something that logically I still feel that rather than surgery, I still feel that freeze embryo and maybe a crash weight reductions by some other alternative method and reaching to the pregnancy of the survivable NICU age, and then we can deliver, and later on for the reduction of the all the cardiovascular means other problems we can, if patient had, then we can advise from bariatric surgery. That is what my logic. I don't know exactly what doing, but everybody is having a less experience because number of the patients are very less. But logically I still feel that it is not a simple surgery. I still feel it is not very simple that complication will not occur after bariatric surgery also.
So yes, actually, I'm just asking from the Indian scenario, how means how I wanted to ask a counseling point of view. In the sense, it's us also. How much should we counsel the patient for pediatric surgery? Like, I am also counseling more for medical management and lifestyle modification as compared to pediatric surgery. Pediatric surgery is the last resort I would give an option to the patient, and even the acceptability is not very good. So, uh, when you are seeing patients, like all the seniors are seeing patients, how is the acceptability level? And do you also like tell them ki yes, you require pediatric surgery now? There is no other option left.
So, ma'am, I would
Well,
like to say that. So, the study has shown that the maximum women who undergo bariatric surgery are in their reproductive age group. So, the main indication for them to opt for the bariatric surgery is to undergo the reproduction.
actually, bariatric surgery is one of the many things which we talk about when we have a lady who's obese, morbidly obese, and trying to conceive. Of course, it comes lower down in the basket of things that we offer. And generally, it is something which is very hard to sell because of availability, because of social issues, because of cost issues, and the fear of the later effects. And this is something which should, the patient should come and ask for it rather than we telling the patient to go for it. Because if the patient asks for it herself, she is more prepared to go through these side effects, which aren't less. I had a very close friend who underwent bariatrics not for the issue of conception but for the concept of a zero size and wearing all the dresses that she loved. And she actually became hypo following her bariatric. I had a resident, my own resident, who underwent bariatrics, and then she conceived after maybe 8 attempts of IVF, with, of course, all the attached mental and physical and social setbacks. So it is not something which is easy to endure. So rather than we telling the person to go through it, let the person come and ask for it. Let the person earn the surgery by her social, and the stigma is not just inability to conceive. It is the stigma of being obese and not looking good. The body image itself is a huge factor. So if she asks for it, yes, she would handle it better. That's my take on that.
At least we can, one take is very important. At least we can freeze the embryo rather than do before bariatric surgery. That will be a great message of this, because anybody, those who are finding out POR and everything, let we freeze the embryo, and then we can explain. So there is no need to say something about first do bariatric surgery and then we will do pickup. It's better than data also coming like that. Do pickup first, freeze it, and then you can advise the patient for any other interval surgery or interval medical management, which will be the best answer. And that Dr. Manjusha tell very good that yes, let the patient speak that what option they want to opt. So that is again good message. I think so. Anything else anybody can?
So one observation I have seen that if in a family there are many obese sisters, and if they have had favorable outcome with obesity and pregnancy, that patient is more likely to respond with conservative, and she did not go for surgery. She can directly opt for IVF and have a better outcome, because those tall and obese, that
Yeah.
they have good prognosis.
So it's all about the ultimately at the end of the day BMI,
Yes.
and sometimes we feel, but it's all about the at what threshold of the BMI we need to work. But you might be right that if they have a good pregnancy rates in the previous, all the mother and everything, then we can counsel. But it's very difficult to, at the end of the day, to counsel the patient to go for bariatric surgery. So answer is very clear in today's era that day by day, because lastly I got a three patients. Today I also have a one patient of PCO, and I never advise them to go for bariatric surgery. I say freeze. I even not discuss. I say that okay, after that we can try for some medical management to reduce your 10 kg, because she is around 102 kg and her BMI is 39.6 today. Today itself, and she is a nursing staff. So I said okay, we can have a pickup, we can freeze, and let's find out certain alternative option of the weight reductions where you might be comfortable according to your psychology, financials, and also the family issues, because this is not a condition that what she can pick and choose immediately.
Yeah, thank you so much, Dr. Jayesh. It's really very fulfilling.
Thank you, Jayesh bhai. Thank you so much.
Thank you,
Thank
sir.
you.
Thank you,
Bye.
ma'am.
Thank you.
I think we have had a very nice discussion. Would you like to sum up things, Dr. Hitendra, if you may, and
Uh,
then we can call it a day?
yes, it was an excellent presentation by Dr. Rudri. And uh, to in conclusion, is that severe PCOS and with very high BMI, more than 35, 40, is always a challenge to manage and to do IVF procedures in such a patient. The question comes whether to do without bariatric surgery or after doing bariatric surgery. This question needs to be addressed very much in detail, but we must look at every case with individualized, in an individualized manner. Which patient needs what, that has to be seen on the merits of the patient's condition, her BMI, and her uh, counseling. All that makes the difference in ultimate treatment of the patient and outcome of the patient, madam.
Thank you so much, sir, for the very crisp, concise takeaways for all the participants.
Thank you.
Thank you, Dr. Rudri. Thank you, Dr. Hitendra. Thank you, Dr. Manjusha. I'll just ask them for the like if any participant want to ask any last question, or we'll wrap for the night. Yeah, I think there are no more questions in the chat box now. Thank you so much. Good night.
Good night.
Thank you, ma'am. Thank you so